What's up, everybody? This is Grant at Cause Artist. Welcome to another episode of the Disruptors for Good podcast. Today, we chat with Aaron Neiderhiser, the CEO and co-founder of Tuva Health, to discuss how his company is transforming the way healthcare organizations handle data. Aaron's journey into healthcare data science has been fueled by a passion for improving access, efficiency, and accuracy in medical analytics. Before launching Tuva Health, he led large-scale data initiatives at Health Catalyst, where he worked on Touchstone, a data warehouse managing medical records and claims data for over 150 million patients. His deep understanding of the challenges in healthcare analytics inspired him to build an open-source healthcare data platform that empowers organizations to harmonize, enrich, and validate data more efficiently than ever before. In this conversation, Aaron shares his vision for scalable, cost-effective, and AI-powered healthcare analytics, the impact Tuva Health is already having, and how open source innovation could reshape the entire industry. Whether you're a healthcare professional, a tech enthusiast, or an entrepreneur interested in data-driven impact, this episode is packed with insights. Great conversation with Aaron. Hope you enjoy it. We'll talk soon. Thanks. Well, thank you so much, Aaron, for joining me today. Super excited to chat about Tuva Health and everything you're up to and everything the company and the team is sort of building. I love technology. And, look, the healthcare system is massive, and it sort of runs on data. And sometimes I think we sort of forget about that. And we are in a golden age of data and what it can be, what it can do. So before we get into everything, Tuva, talk a little bit about your journey before then. What was sort of your path before starting the company?
Yeah, thanks for having me, Grant. So to start off, I never thought about getting into healthcare when I was younger. It was never something that was on my radar. I was wrapping up graduate school in economics and wasn't quite sure what I was going to do next. And one of my professors was like, hey, you should go talk to these guys at Colorado Medicaid. They're doing some cool stuff. Mm-hmm. They could really use some help with data analysis. I was going to school in Denver at the time. And my response to that was kind of like, well, I don't really care about healthcare. It's not super interesting to me, but I fancied, like any good economist, you think you're like a pretty good data analyst. So I was like, I'll go talk to these guys, right? And that really turned into kind of a reality minus expectations sort of situation where my expectations for the meeting were like super low. I was like, I'll go talk to these guys, but I'm not going to take a job there. I'll just see what's going on. But then, meeting with the person who would become my boss and his boss, they started talking to me about, do you understand how healthcare is paid for? And fee for service, and we're trying to and how that's like not really aligned with that there's not good incentives in the system in a fee for service model, and we're trying to change that in Colorado and do things like bundled payments or value-based care. And this was like circa 2011. This was like before Obamacare and the ACA was like just kind of it'd been passed in 2010, but it was like just being kind of turned into the law was actually, just being rolled out kind of. And the state of Colorado was already starting like a statewide kind of accountable care program where you kind of change the way you pay physicians for the quality of care they deliver as opposed to just like the fee for service model. Mm-hmm. And so that was like really interesting to me. I was like, oh, okay, because that like kind of tapped in like the economics, like incentives part of my background in a way that I didn't like appreciate before. And then the other thing that was very interesting to me is they were like, oh, and by the way, like this is probably why you took the meeting. We have a really interesting data set. We have a longitudinal data set on 1 million patients going back 20 years, 1 million people in the state of Colorado going back 20 years on all their like conditions, procedures, the healthcare services they receive, all the doctors that treated them. And if you're a data analyst, that's like a pretty interesting data set, right? It's like the holy grail is like, man, I wonder like which treatments are working best for different types of patients, right? And which like, and so long story short, ended up joining full time just as essentially a data analyst, right? Okay. And so I was like the data analyst that kind of was on point as they rolled out that program, kind of analyzing the data to kind of operationalize the program, like which patients were attributed to which doctors, but also to measure like, is the program working or not? And so I remember being like really excited like starting and being like, oh, I'm going to get access to this great data set. And then immediately it turned into like claims data, health insurance claims data was the data. And I immediately, after I got access to the data set, realized, oh my gosh, like this is so esoteric. I don't understand what any of it means, right? Like I have to go like learn healthcare to be able to understand what the data means. And so I essentially ended up just like really bothering a bunch of people who had that domain experience for the next like 6 months, right? Until I was able to like be effective and like analyze, know how to analyze the data. And so this is like kind of the beginning of the seeds of like, now with Tuva, one of the problems we're trying to solve is like working with healthcare data just requires so much domain experience. And how do we make that knowledge more accessible, more open, so that more people can like level up and be more effective in doing higher quality analytics faster? Because not everybody has the people that I had access to at Medicaid who are so willing to like train them and help them understand, hey, here's how things really work. So that was how I initially got into things.
Yeah, healthcare data it's sort of this like it's an immense data source that now obviously we have AI coming to the forefront. We sort of have the ability to analyze data, but perhaps understand it better, not just the data, but also the terminology involved in it. I guess talk about healthcare data space, not maybe when you entered it, but when you were really considering starting, Tuva to maybe now. And what are the differences and why open source? What sort of benefits does that give to the sector and to Tuva and its customers as well? And also, eventually patients much downstream are not going to really know what Tuva is, but it could play a big role in sort of their, the protocols they receive and sort of the healthcare they receive in the future.
Yeah, I mean, there were really kind of three key ideas that pushed us into thinking that open source could be a really interesting approach for the problem space. Prior to starting Tuva, I was working at a company called Health Catalyst. That's where I went after Colorado Medicaid. They're one of the earliest companies kind of in the healthcare data warehousing analytics space, and still are today. And I spent 7 years there. Along the way, met my now co-founder, Coco. We actually met in downtown Salt Lake. We both moved to Salt Lake City around the same time. We met downtown playing squash and kind of quickly realized we were both working in healthcare data science. Yeah, it was super random. I can talk more about that. That was just completely serendipitous. But basically, like kind of like circa 2020, circa 2021, like I'm at Health Catalyst, Coco's leading data science at Strive Health. We're playing squash, and in between games, we're talking about all the stuff our teams are working on. And it's all the same stuff. It's all this kind of like, it's the laundry list of kind of different like capabilities that you need in your data stack to go from raw claims data, raw medical record data to data tables that are ready for analytics. So it's things like a universal data model to combine claims and clinical data marts for enriching the data, access to all the terminology sets and code sets in your data warehouse. And the first thing that we came to, which ended up being one of the key ideas behind the open source, is like, geez, everybody is just rebuilding this stuff over and over again from scratch and has been for 30 years.
Wow.
Like ever since claims data started to become more widely available, which I would say is like roughly speaking, like late 90s, early 2000s, it starts becoming more widely available for like care delivery use cases, but also secondary research use cases on a de-identified basis. Everybody's been rebuilding kind of this healthcare data transformation stack from scratch. And to give you a sense of like how much work that is, like we've spent well over 30,000 hours so far collectively building the open source. And I think we are 20% of the way done or something like that, right? So it's just like a huge problem. And that was really the first thing is like, geez, everybody is reinventing the wheel on this stuff. If we spend all our time building this stuff, we're not actually spending any time analyzing the data.
Interesting.
And Coco and I were both data analysts. Like that's what we wanted to do with the data, right? Answer interesting questions around how care is being delivered, where could it be delivered more efficiently, how could it be delivered more efficiently. But if you don't have data in the right format with the right concepts in it to be able to do the analysis, then all your time is spent transforming it just to get to that point. And that's what our teams were doing over and over again. So how could we like stop the industry from reinventing the wheel on this stuff was kind of the first key idea. The next key idea was really around transparency.
Mm-hmm.
Like there's lots of different kind of approach, like methods, right? You could use to transform the data. Like let's say, take the concept of like a hospital visit.
Yep.
Right. It's like, okay, the healthcare data set probably has the concept of a hospital visit in there somewhere. Claims data sets that doesn't exist in claims data sets. There's all this kind of like more granular atomic level information that you have to combine to create the concept of a hospital visit. It's kind of like, atoms are made up of protons, electrons, and, ultimately below that quarks and, finer, like lower level particles. You got to combine all that stuff together to get to the atom, the higher level concept, which is the atom. It's kind of the same thing with healthcare data. And there's different ways to combine those things. And if you take two different methods, like, method A for creating the hospital visit from the atomic level data and method B for creating the hospital visit for the atomic level data, and you then use that data, the data coming from those two methods to answer the question, how many hospital visits do we have over the last year? You're going to get two different answers. Okay. So the methodologies are super important. And we knew it was going to be important to have transparency into these methods. So as an industry, we can decide what the right approach is, and we can actually see what's happening under the hood. So that was really the second key idea, where we thought open source was important. And the third key idea was kind of this really exciting idea, which is okay, if we build essentially this kind of healthcare data transformation stack, right? Where it's all these things that take you from raw to data that's ready for analytics. And we open sourced it. And so we got a lot of people to use it because it's helping them not reinvent the wheel. So they save a bunch of time, and they can use it in a fully transparent way. What is the consequence of a lot of people adopting that, right? What if in the limit, every healthcare organization ended up adopting that? Well, then you would essentially have all the world's healthcare data in the exact same quality tested analytics ready format. And the consequence of that would be anyone running an analysis on any of those, let's say somebody wants to ask a question around hip replacement or multiple myeloma, or take any question, then all that code becomes completely reusable because it can all run on the exact same quality it's tested. Essentially, it can run on the Tuva data model. And so then we saw that as the potential for really speeding up the amount of high quality analytics that was happening in the whole ecosystem, and really kind of even substantially moving us as an industry much closer toward the goal of creating a learning healthcare system where we can actually learn from the collective experience of every patient to understand what treatments are working best, and how to best deliver care. So, and we saw that the only way to really get there at scale was through open source, to have something that could be freely adopted.
When I speak to anybody in any sector, right, sort of the end goal is if the product or the company hits sort of its perfect sort of scenario of what the company can be, how does it positively impact sort of the world? Obviously, healthcare data has a lot of downstream impacts. In the perfect world, as Tuva scales, it gets to a certain point. How can it sort of impact the world in a positive way? I mean, open source has just so much potential, and obviously with AI coming on board, y'all are set in such a prime area. But at its peak, what does it do to transform the healthcare industry, which then obviously transforms the world in a lot of different ways?
Yeah, I mean, I think the answer to this, if anybody's working in healthcare and they're trying to honestly answer this question, the answer has to go back to how is this impacting patients?
Yeah. Yep.
Because what are we doing?
Yep. Exactly.
Why does healthcare exist? Right?
Mm-hmm.
It is at bottom all about patients. And I think, a common quote about the industry I forget who first said this, but it's been like a bunch of people have kind of repeated it since then. I'll have to figure out who it is so we can get credit. But like healthcare isn't one market, it's 10,000 markets, right? And like similar to that, it's like there's not like one type of patient. There's like 10,000, 100,000 different types of patients, right? And so if we're like thinking about like how do we make things better for patients, using data to make things better for patients, that's why using data for making things better for patients is such a complex problem, because you don't have to, it's not just like one analysis, right? It's 100,000 different analyses, right? And that was always my, like, everywhere I've worked and every organization I've ever worked with in healthcare, we never kind of get past like the basic questions. It's kind of like, okay, we're analyzing readmission rates for patients with congestive heart failure because that's what CMS told us is important, right? And there's like a bullet list of like, usually most organizations have a bullet list of like maybe like a couple dozen of those things. And we never get past that list. Because if I want to really like drill into like, to take multiple myeloma as another example, if I want to really drill into like I may only have, depending on the size of my organization, multiple myeloma may not be a huge number of patients for me. From like a patient volume standpoint, it might not represent a large portion of the total cost of care. And so like, I just never end up using data to try and understand how care is being delivered to that population, what treatments are working better, is the new therapy that's coming, are patients getting the new standard of care that just came out, or like are certain doctors not prescribing that? If not, why not? Like, and it would just be because the data wasn't available. It was trapped in the raw form, and it wasn't available to be able to quickly answer those types of questions. So that's, I think, at scale, the broadest potential that Tuva has is now we can like look at how care is being delivered in a transparent way for any population in a way that takes a couple of minutes, as opposed to essentially never being able to do it because you just have to start from scratch every time.
Kind of deep dive on the data a little bit. Who are, I guess, the customers or the use cases?
So the customers are basically any organization in the healthcare ecosystem. So what I mean by that is like, think about health systems, think about payers, insurance companies, think about life sciences organizations. Basically, it's anybody that has what we would call population scale healthcare data, meaning clinical data or claims data for the most part. If you're a health system, you have an electronic health record, right? Like Epic or Cerner, right?
Yep.
And you have the data from all the patients from that system. Or if you're a payer, you have your claims data set from all the health insurance claims that have been submitted and adjudicated and paid, right? And if you're a life sciences company, you're actually buying de-identified copies of that data to try and understand, hey, I'm like developing these drugs. Where do they fit into the market? And how am I going to find patients to run clinical trials? And kind of as a result of interoperability over the last several years has made it easier for these organizations to share data. Kind of as a consequence of that, and some of the value-based care like partnerships that have really emerged in the industry over the last decade, organizations aren't just dealing with one data set anymore. Like it used to be the case, like I'm a health system, I just have my medical record and that's it. Now organizations are dealing with 10, 20, 30 or more of these data sets. And so then the scale of this challenge becomes a lot greater, right? Because now I'm not just trying to clean up and transform one data set. I'm trying to do that across 30. And all these data sets refresh on different frequencies, and they all have their own kind of data quality challenges. So that's who the customer is, and that's kind of the type of data they're working with, and kind of the challenge of the volume of data. A nice consequence of open source is all of Tuva runs inside their cloud. So what I mean by that is they'll have their data sets, and they'll have them in a data warehouse somewhere. Maybe a data warehouse like Snowflake or Databricks, being some of the two, kind of modern ones that are essentially kind of best in class today. But there's like, a number of different data warehouses. Organizations that use Tuva get to keep all their data in their data warehouse, and then they bring all of this transformation logic to their data warehouse. So as an
Gotcha.
additional benefit of the open source is they get to retain control and security over overall their data, versus kind of in the old model is like, I would, if I wanted to have a vendor help me with this, I would have to send my data to them, and then
Correct.
I would
Yep.
lose
Right.
control. I wouldn't have
Yep.
transparency into what's happening. And so that's kind of another added benefit of the open source.
How does the sort of regulatory environment play in data sharing in healthcare? Does open source help with that regulatory environment and policies that are made? I guess where are we at on that front? How difficult of a challenge is that? Is it getting better? Does open source provide a better way to be in line with these policies? Like,
Yeah, it helps a little bit. So all of this is kind of regulated under HIPAA.
yep.
And so kind of like the standard model is kind of like the organization, and this only pertains to if we're actually talking about PHI, protected health information. If we're talking about EHR data or claims data that has been de-identified, like
Yep.
pharma might have, none of this
Yep.
actually applies, because kind of an interesting consequence of de-identification is once PHI is quote unquote de-identified, and that's like a specific process and means something specific in the industry, HIPAA doesn't actually have anything to say about it anymore.
Okay.
So if we're talking about population scale, like medical record data or something like that that's been de-identified, HIPAA doesn't have anything to say. But let's say we're talking about a health system or a payer and we're talking about PHI. The
Okay.
typical way that a vendor would work, like another healthcare analytics vendor or somebody would work with one of those entities, is they would sign what's called a business associate agreement. And
Okay.
this is like a specific kind of like pathway under HIPAA that basically says, hey, health system or payer, you are working with this vendor, and they are going to be your business associate, and this is kind of the legal pathway that gives them legal access to the data under HIPAA. And so one of the nice cons, and before that's in place, nobody can do anything, nobody can touch the data, like that has to be in place. And so if you're like, imagine you're on the data team at a payer or a health system, and you see this new tool and you want to try it. You want to
Okay.
try it out, right?
Yep.
I can't do that unless I sign a contract unless I sign one of these business associates agreements. That's an
Gotcha.
enterprise level agreement. A junior person, any person on the data team is not going to have the authority to sign that. And so I can't try any of these tools that I need to do my job without getting sign
Gotcha.
off in a contract from up here. But with open source, again, it's different because no data has to move. We're not touching data, right? The tool is coming to them, right?
Yep.
And so they don't actually have to, it would be like, it's like them just, using a new data engineering tool, kind of, right, to do their
Love it.
job.
Yeah.
So they can
That
try
alone
it
is
out, and
huge. That alone
yeah,
is huge. That little hurdle that they don't have to go through, they can just try stuff out is amazing. A couple of days, they could try things out. If it works for them, if it doesn't, they can move on. But if it does, I mean, they could start to really play around, dig deep into it, and really get going much faster to see if it's right for them or not.
100%. Yeah, I mean, I don't think it's really like from a business standpoint, it's not really a pure like product led growth sort of motion, but
Yep.
it is different than other models in healthcare, at least.
Like when we talk about open source, like, immediately traditionally, I think of free, right? I think of this as it's a free tool. It's open source. Anybody can sort of use it, make it better, blah, blah, blah. So like, how does Tuva make money? Like, what's the business model?
We have this core open source, which includes all of this kind of like transformation. It includes this like universal data model, all these data marts for building advanced concepts in the data, all the terminology sets. There's like more than 50 kind of like terminology code sets and reference data sets that you need to
Gotcha.
work with healthcare data, all the data quality testing. That's all part of the open source, and that runs inside their data warehouse. And that's completely free, right? So there's different open source licenses. This is kind of like a nuanced topic, but like the license we use is Apache 2, which is like,
Okay.
that's actually open source. Like somebody could literally copy the Tuva code base and the next day call it their own, and that would be within the rights of the license. Now, that might not be the nicest thing to do, but technically that's fine. Versus like some other open source licenses are a little bit like, that doesn't really, like, you have all these kind of restrictions on use that it's not really open, right? So that was kind of important to us. So then around that's all the open source, but then around that we are building software, like add-on software that customers can use to solve two challenges. How do I get all of my data sources into the data model at scale? So like if, we work with organizations that have 20, 30, 40, 50, 60 data sources that are refreshing daily, weekly, monthly.
Yep.
How do you manage all that?
Yeah.
Right. The ETL orchestration, deduplicating patients across those data sources so it's modeled in the data model the right way. So that's software kind of on the data transformation side. And then secondly, we're building software that runs on top of the data model. So how can we automate a lot of the most important advanced analytics use cases with analytics applications, with data products like risk-adjusted benchmarking that will enhance value for the types of analytics the organization is trying to do. And both of these things we're building them to integrate very tightly with the open source. So as an organization, if you kind of like decide and go, hey, we're going to use Tuva as the data model, as the analytics ready data model, so we don't have to spend all this time reinventing that wheel, but then they encounter these other problems around it, they can just turn on those solutions with a light switch, like turning on a light switch. So that's kind of the idea behind that and kind of the business model.
I have to talk about AI. The pace of it is moving so fast. The amount that I use it in my daily life has gone up the last 6 months for sure. I imagine that you and the team are pretty giddy about the possibilities of running AI on data in general in any sector. I guess just talk about maybe the last year for you guys, maybe using AI in certain areas, practicing with some of those models. What do you think is going to be sort of the fruit of that labor where AI is sort of implemented into healthcare data at scale? What are the possibilities there? What are you seeing right now, and what do you see can happen in a few years?
I mean, maybe I'll just give you a flavor of like the practical now and kind of like maybe some of the exciting stuff. I mean, the most practical thing for us right now is like coding. I'm a technical person. I'm the least technical person on the team now. But we're still an early stage company. I still do some coding, but not as much as I used to. And so my skills are not nearly as sharp as they used to be. There's some things that I'm working on where I'll need to create like a chart for some sort of visualization or something.
Oh yeah.
It'll be like I will be able to do stuff in 5 minutes that if I didn't have it, I would have to spend like a day just because I'm not like as into it as I used to be, right? So it's just absolutely transforming the speed of development. That's not news. Everyone's been talking about that.
Yeah, but that is, just for those who don't know, I mean, that is you just having data, prompting the model to say, hey, based off this data, create me a graph or a chart or something like that.
Well, and more specifically, what I'll do is like, I'll just work with Chat GPT, right? They're paid like 4.0, the paid version. And I'll just be like Chat GPT doesn't even have access to the data. I'll just describe the data. I'll be like, hey, I got a data table like this, and I want a chart that looks like this. Give me all the pandas Python library transformation to do that so I can run it in my Streamlit app. And it'll just be like, right, it'll just spit it out. And it doesn't always get it right, but it gets it close enough that you can kind of go back and forth and give it the air that after a few minutes it'll get there. And it's like, okay,
you're still saving an immense amount of time.
It's nuts. Yeah, it's super nuts. They just rolled out this thing called Canvas in the last week, which is like a better UI for doing like OpenAI is iterating like so quickly on all this.
Yeah, it's crazy.
And like I forget what the timing is, but I think we're going to get Facebook is going to release like new versions of Llama this year that they're training right now. And
open source Llama.
Yeah, the open source Llama. And then Grok, Elon's company is like training their like big next gen model right now, and that's going to come out in the next couple of months. And so I think we're really going to see like, is like improvement really slowing down? Like some people are worrying about like pre-training improvement slowing down, or like, are we going to still get gains from these like bigger and bigger models? But that's going to be super interesting to see. One really practical thing that we'll see come out in the next, like we're kind of starting to prototype this now, and this will be like a product in the next couple of years, is essentially, with Tuva, there's still all this kind of, when you use Tuva, there's still all this like bespoke kind of like wiring up of the raw data into the data model, right? So and that's a person going in and kind of doing normalization, like, hey, the format looks like this over here. I need to like conform it to the input of the Tuva format, kind of like mapping to the API sort of. And that can take a lot of time. And I think we're going to fully automate that with AI. And I think we'll get to the point where it's like, it doesn't really matter what the input format is. Is it structured data from an EHR? Is it unstructured data? Is it PDFs? Like, it doesn't matter what it is. The AI can just take that and then like turn it into, like, plug it into the data model. And so I think that's really going to increase efficiency for the data engineers that are doing that work today. And then I think, so that's kind of the very practical one that I'd say is like basically 100% for sure in the next like kind of like year, 2 years kind of. Then there's like the what, like looking further out, what actually happens. And I think it's going to be really interesting to see what happens. But there's like, I think there is like a world where, but like in healthcare, there's a lot of AI scribe companies. Do you know about this? Mm-hmm. Which is basically like, so the old work, like clinical workflow is like you go to the doctor, and anymore your doctor's just sitting in front of a computer. Right. And they're talking to you, but they're really just like hammering away at the computer.
Inputting their data as you talk to, they're inputting your answers essentially, or
Sometimes they have a medical assistant doing it, right? Mm-hmm. Sometimes there's somebody in there with them. It just depends. But like, it's just, not ideal. So one of the technologies that has, been possible since, with the new large language models is basically this AI scribe technology. And what that is that's basically AI like listens to the conversation, right? Records the conversation as like I actually don't know specifically how it works, but I'm pretty sure it's like something like it records it as like a WAV file, right? Sure. The WAV file gets transcribed into text, and then that text gets like plugged into the EHR, so that it kind of automates that whole scribe process. There's an interesting potential consequence of this from like an analytics and research standpoint. The data, one of the big problems with electronic health record data is how messy the input of that data is into the EHR. Doctors are just too busy; they're just typing furiously, right? So at a minimum, that should become a little bit more standardized and a little bit cleaner as AI does that. And I think that's going to be the interesting consequence of that is like, if you take, there's kind of like, if you or I got sick and we go to the doctor, what would the doctor record? Right. It's going to kind of just be like some rant, this medication, hey, this thing, but it's not going to be in a super, like, it's not going to be the best documentation in the world, basically.
Sure.
On the other hand, if you and I were participating in a clinical trial, that documentation is like a scientific experiment, right? So that is like, that is going to be some good data, right? So one interesting consequence of this is we're just going to probably have better data because the AI scribe is just going to be doing this in a more complete, probably more systematic sort of way.
So the scribe part would really come into play for those trials, stuff like that is where that could really excel. If you record that.
Yeah, I mean, but it's almost like bringing the rigor of documentation that would occur in the clinical trial process to like average care delivery that's happening in your doctor's office or something like that. There's even like a further potential consequence of this, which is like, is the data even stored in structured data tables anymore? Like what it like?
So like, does it have to be? You mean like?
Yeah, exactly. I don't think so if it's not stored in structured tables, where is it stored? I don't think it's stored in the weights of the model. That doesn't make sense to me. But it could just be stored LLMs basically run on text. So you could imagine just tons of text, and then you could have this more at runtime, at analysis time, the AI is generating the data tables that are needed for that analysis. I think this is pretty far out. Here's what I think. I think at bottom we're talking about statistics. What was the length of stay? Medical statistics. Anytime you're talking about computing a statistic, you're talking about doing an operation on a list of data, right? If we recorded 10 people's heights, right? I'm 6 feet, you're 6'1", whatever, right? You're doing the average, right? That's a statistic. So before let's say the AI does all this, right? Before it gets to the last step where it computes the statistic, the data is going to have to be in a list of numbers. So it is going to have to kind of create a data table before it does the statistics. But what I'm maybe positing is maybe we don't have this big data model back end of the EHR that we have today. Maybe it's just all text. And maybe the AI is generating those data tables kind of at runtime as the user is hey, we're trying to understand this question. And then it goes back and does kind of a custom thing. I could maybe see that.
I'll end on the last question here is just a little bit about the future. I know it's tough to sort of predict things, but over maybe the next 3 to 5 years, what are some of the goals and successes you and the team would like to achieve?
Yeah, I mean, from the beginning, we've really thought about the company in 3 phases. The first phase is building the open source. And we've effectively been successful in that phase. We're kind of done with that phase, entering the next phase. At the beginning of last year, 2024, we had 3 organizations using the open source. Today, we have more than 30. So it's we've really proven out the value of it from an enterprise adoption standpoint. The second phase is what we call the data platform, which is okay, we've got all this, kind of this is good open source stuff. But if you're going to operate a healthcare data platform at scale, you need all that software that I mentioned around it. So building out that software to really help enterprises use the open source at scale, and that's probably a couple years. And then continuing to grow the open source adoption along with the build out of the platform. And then if we're successful there, we should have several hundred organizations. If you look out 3-5 years, we'll have 3, 4, 5, more than 500 organizations using the open source. And I think this is where we get into the third and final phase of the business, which is kind of the most exciting, which is AI and the data network. I mentioned that possibility at the beginning of one of the consequences of open source is what if everybody's data is in the exact same quality tested format, right? We would have all these reusable analyses that the industry is using to really accelerate the knowledge and the intelligence that we're getting out of this data. So that's kind of a big part of the third phase. But then back to our AI conversation, then starting to build AI into all these products to basically make them more effective, more efficient, whether that's on the data transformation side or whether that's helping the analyst generate more interesting analyses faster. So that's kind of the trajectory. Still at the early stages, lots of fun ahead of us. So it'll be interesting to see how it goes.
Awesome, man. Well, thanks, Aaron. Thanks so much for taking the time. I know you're busy. Always grateful when people take their time out to talk about their journey a little bit. Some of the goals and successes they'd like to achieve and what they're working on. It's super interesting, man. So best of luck to you and the team for the next decade to come.
Awesome. Thanks for having me, Grant. This was great.